15th November and the patient was examined on 27th November. Chief complaints: pain in the left leg for 1 year, blackish discoloration of the 4th and 5th toe of left leg for 1 month. History of presenting illness: the patient was apparently normal 1 year ago, after which he developed pain in the left lower limb, which was gradual in onset and progressive in nature. The patient initially experienced pain after walking for a short distance, and now for the past 4 weeks pain persists even at rest. Pain is aggravated on lying down and relieved on hanging his legs from side of the bed. Blackish discoloration of the 4th and 5th toes of the left lower limb for the past 1 month, which was gradual in onset and progressive in nature. The discoloration started from the tip of the toe and now has progressed to involve the whole toe. No history of gluteal claudication, thigh claudication or calf claudication. No history of impotence. No history of superficial thrombophlebitis. No history of fever. No history of chest pain, palpitation or breathlessness. No history of transient ischemic attack. No history of transient blackouts or blurring of vision. No history of abdominal pain or postprandial pain. No history of weakness of upper limb. No history of recent trauma. No history of exposure to heat or cold. Past history: no history of similar complaints in the past. Patient is a known case of diabetes for the past 17 years on regular medications, and patient is also a known case of hypertension for the past 17 years and on regular medications. No history of coronary artery disease, stroke, asthma, epilepsy or tuberculosis. No history of any previous surgeries or no history of any bleeding disorders. Family history: no similar complaints in the family. No history of stroke, cardiovascular disease, diabetes or hypertension. Treatment history: tablet metformin 500 mg BD for 17 years. Tablet telmisartan 40 mg OD for 17 years. No history of allergy to any drugs. Personal history: diet mixed, normal appetite, disturbed sleep, bowel and bladder movements regular and normal. History of smoking for the past 20 years, 20 cigarettes per day, which is equal to 2 packs, and the smoking index is 40. Drinks alcohol occasionally. So the general examination will be continued by Megha.
General examination: consent was taken from the patient and the patient is examined in a well-lit room with...
You can go back to the history.
What is blackish discoloration?
Blackish discoloration is maybe due to gangrene. The area may be without blood supply, it turned black.
So what is the cause for black?
Hemoglobin breakdown and iron sulfate deposition in the toe.
Iron sulfate deposition. Okay.
What is gangrene?
Macroscopic tissue death.
Types of gangrene?
Dry gangrene, wet gangrene, mixed gangrene.
Which one is dangerous? Dry gangrene or wet gangrene?
Dry gangrene. Dangerous. Wet gangrene.
Why?
Because it may extend proximally and sepsis may also occur because of a lot of bacteria it is favorable for bacteria to be in.
Okay. How to differentiate dry gangrene from wet gangrene?
In dry gangrene, there is a clear line of demarcation. In wet gangrene, there is no clear line of demarcation, and it is separated by aseptic ulceration in case of dry gangrene, and there it is septic ulceration, and it is dry, shriveled, mummified appearance. There it is wet in appearance, and
okay, enough.
Can you explain the pain in this patient? History of presenting illness. Come to the next slide. Yes, explain about the pain.
First, he had pain which was intermittent in nature. When he was walking for a short...
What was the site of pain?
Foot.
Only in the foot. Okay.
So first he had pain while walking for a short distance. Later, after it progressed to rest pain, which is...
Can you explain the pain according to the Boyd's classification?
Now it's rest pain, ma'am. So it is more than...
So what is Boyd's classification?
Boyd's classification is for claudication pain.
What is claudication pain?
It is brought on by walking. It is relieved by taking rest, and it is cramp-like pain.
Usually felt in the commonest site.
Calf claudication.
Calf
is more.
claudia. Claudia means what?
Eye limp.
Eye limb. Okay.
So what has happened now? So initially he has had intermittent claudication and now he is progressing to
The rest pain.
rest pain. So where is the level of obstruction according to the clinical thing? He is having pain in the foot. So where do you expect the occlusion?
Uh, According to on examination, pulses were not felt in the tibial
No,
arteries.
here
No, clinic.
Here,
he has pain
foot
in
claudication
the foot.
means tibial arteries mostly.
Right.
So what is the cause for rest pain?
Cry of dying nerves. The vasa nervosa is not getting enough blood.
The ischemia of the nerves.
Ischemia, cry of dying.
Why the pain is relieved on hanging?
Increased blood supply due to gravity. When the patient keeps his leg hanging, the blood supply is improved.
Okay. Next leg.
This is history, no? History of Black's discrimination.
Let me get down. Get down. Next.
In case of iotoiliac obstruction, there may be Lirith syndrome, so which may lead to impotence.
So you have asked about chest pain, breathlessness, TIA, blurring of vision and abdominal pain. Why are you bothered about that?
In peripheral artery occlusive disease, coronary arteries and carotid arteries may be involved, so they may have symptoms of CAD or stroke.
No, it's
With-
usually a generalized disorder. This is not a localized disease, unlike like a hernia and all. This is not a localized disease. Arterial occlusion is a generalized disorder. If it is an atherosclerosis, it's going to be a generalized disorder. And no patient will die of an ulcer. He is going to die of something else. All patients with the peripheral occlusive arterial disease, the cause of death is mainly going to be the other things, not the ulcer per se. Okay, so you need to know, ask elaborately regarding all these symptoms, right?
Why you asked about abdomen pain?
Mesenteric occlusion, mesenteric artery occlusions, or abdominal aortic aneurysms.
So how will be the pain in abdominal mesenteric?
Postprandial pain after taking meals, especially he'll have pain, which is severe. So he might not take food.
Right. Next slide. Why are these important? Diabetes, hypertension.
Diabetes itself is a risk factor for peripheral artery occlusive disease, and that also may lead to less blood supply due to ischemic neuropathy.
Yes.
And in hypertension, it is due to a
If it is associated with diabetes, what type of gangrene is common?
mixed type of gangrene.
Mixed gangrene. Yes. Mixed ulcer and mixed gangrene. Right. So are you bothered about this previous surgeries? What surgery?
In case of any embolism, they might have undergone any surgery or
Right. Any surgery can occlusive. Previously, you would have undergone surgery for occlusive arterial disease, maybe some cardiac, cardiovascular surgeries. So all these are important. Right. Next.
Next. What is the relation between smoking and atherosclerosis?
yes. Smoking may cause deposition of
Cancel பண்ணி சொல்லக்கூடாது.
smoking causes deposition of it tunica intima maybe.
Now, what are the factors which are released when patient smokes?
Nicotine and
So, what happens because of nicotine?
vasospasm.
That is the risk factor.
That is the risk factor, not the intimal. Intima is injured or involved in which disease?
TAO.
TAO.
How
And
to differentiate?
TAO is wrong.
Atherosclerosis.
How to differentiate atherosclerosis from TAO?
First age, in TAO patients mostly the less than 45 years old, in atherosclerosis more than 50 years old, and according to gender, generally males genders are more prone for smoking, so they'll have TAO is more common in males, and atherosclerosis is equal, but also males are more involved, and bilateral involvement in case of atherosclerosis mostly, unilateral in case of TAO, and from distal to proximal in case of TAO, and proximal to distal in case of atherosclerosis.
Then any other?
Um,
Usually in atherosclerosis, intima is affected.
Intima is affected.
Here all layers
All
are
pan-
affected. Okay. Next.
General examination. Consent was taken from the patient and the patient is examined in a well-lit room with adequate privacy. The patient is conscious, cooperative, coherent, oriented to time, place and person. Patient is moderately built and nourished, BMI 26.4, not anemic, not jaundiced, no clubbing, no cyanosis, no generalized lymphadenopathy, no edema. Vitals, temperature afebrile, respiratory rate 16 breaths per minute, pulse rate 80 breaths per minute, regular rate and rhythm, adequate volume, no vessel wall thickness, no radiofemoral delay. Blood pressure taken in the supine position, right and left upper limbs showed 110/80 mmHg, right lower limb showed 120/80 mmHg, left lower limb BP was not recordable. Examination of lower limb. Patient is examined in supine position with both limbs exposed from anterior superior iliac spine to toe with adequate privacy in the presence of an attender after taking consent. Inspection. Inspection of left lower limb in the supine position was done. Attitude of the limbs. Limbs were hanging down the bed. Stretched, shiny and thinned out skin is seen over the lower limb. Loss of hair and subcutaneous fat on the lower limb. Brittle nails, skip lesions seen on the plantar aspect of the foot. Heel scar of 4 x 4 cm was present on the dorsum of the foot over the medial malleolus. Dry, shriveled, blackish discoloration of the 4th and 5th toe with clear line of demarcation seen 2 cm below the base of the toes. Wasting of the calf muscles are noted. Buger's vascular angle was found to be 40 degrees. Capillary filling time was not appreciated. Venous filling time was delayed. No engorged veins seen over the limbs. No scars present over the limbs. Palpation. The left leg is cold when compared to the right leg. Capillary refilling was prolonged. Venous refilling was delayed. Cross leg test or Fuchs test was negative. Gangrenous area. The gangrenous toe is hard and shriveled. Extent. Blackish discoloration with necrotic tissue was found over the left, 4th and the 5th toes involving the whole toe with clear line of demarcation. Tenderness is noticed at the junction of gangrenous area and normal tissue. No crepitus, no edema. Movement of the joints adjacent to the gangrene was found to be normal. Peripheral pulses. The right dorsalis pedis artery was found to be normal while it was absent in the left side. Anterior tibial artery was found to be normal on the right side while it was absent in the left side. Posterior tibial artery was found to be normal in the right side while it was feeble in the left side. Popliteal artery was found to be normal on the right side and reduced on the left side. Femoral artery was found to be normal on the right side and reduced on the left side. Radial artery was found to be normal both on the right and the left sides. Brachial artery was found to be normal on the right and the left side. Common carotid artery was found to be normal on the right and the left side. Superficial temporal artery was found to be normal on the right and the left side.
So how many plus? Usually we see only 2 plus will be normal, 1 plus is feeble, and minus is absent. Where did you get this? 3 plus.
3 plus we meant normal, sir. In 2 reduced and 1 is feeble and then other is absent.
And usually you should examine
From the superficial.
superficial to the deeper. Sorry, superficial topmost is femoral artery first and dorsalis pedis should come below. Reverse.
Okay, okay, continue.
So where do you palpate the dorsalis pedis artery? So have you completed the examination?
முடிக்கல.
No, ma'am.
Complete.
Complete.
Auscultation, no murmur or bruit was heard over the major vessels. Reactive hyperemia test greater than 6 seconds. Neurological examination, tone of the muscles was normal. Power of the muscles was 5R5 in both limbs. Bulk of the muscle, calf muscles of the right limb was 35 centimeter and left muscle was 29 centimeter. Thigh muscle was on the right side was 50 centimeter and on the left side was 50 centimeter. Sensation of the gangrenous area is lost. Examination of lymph nodes, no palpable lymph nodes. Examination of right limb was normal. Systemic examination, cardiovascular system, C1 and C2 is normal, S1 and S2 normal, no added sounds. Respiratory system, normal vesicular breath sounds heard. Abdominal examination, soft, non-tender, no organomegaly. Central nervous system, no focal neurological deficit.
Summary.
Summary, so a 42-year-old gentleman hailing from Cherupallur came to, who is also a chronic known case of diabetic and hypertension for the past 17 years and is a chronic smoker for the past 20 years, came to the OPD with chief complaints of pain in the lower left limb for past 1 year and blackish discoloration of the 4th and 5th toes of the lower left limb. Upon examination, on inspection, it was found that the skin was dry, shriveled and thinned out with loss of subcutaneous fat and brittle nails. On palpation, on inspection, 4th and 5th toes were found to be discolored with clear line of demarcation, gangrenous. And then on palpation, the region was found to be cold. The capillary filling time was found to be prolonged, and there were absent pulsations in the dorsalis pedis artery and the anterior tibial artery.
Okay, go to first slide. Inspection.
What is the reason for stretched, shiny, thinned out skin?
There will be
Was it present in the entire lower limb or up to which level?
from no, yeah, in the shin area.
Shin area.
Below the
What about the dorsum?
dorsum. The its skin was shiny, ma'am, but there was no loss of hair because generally we don't have hair in that area.
What is the reason for stretched, shiny, thinned out skin?
Or loss of subcutaneous fat.
Okay, next. What is Borger's vascular angle?
There's a test called Buger's test in which we ask the patient to lie in supine position and then we ask the patient to raise his legs one by one without flexing the knees. Generally, when the patient lifts in an ischemic limb, the patient starts experiencing pain or pallor is noticed. So the angle at which pain is appreciated or we see pallor is known as Buger's angle or vascular angle.
In this case, is it normal or abnormal?
It is abnormal.
How to do capillary filling time?
Capillary filling time, we again ask the patient to lie in supine position and elevate his legs, and then we ask the patient to sit down and hang his legs. So, generally, in
The color will be pink.
pink. But when the patient is ischemic, it would progress from pink to purplish.
Change its color from pale to pink. The time taker for change in color is noted. That is capillary filling time. Venous filling time.
We ask the patient to elevate the leg and keep it on the bed, and we notice the venous filling time. If it's more than 5 seconds, it is.
What is capillary refilling time?
Capillary refilling time is done in palpation, wherein we apply pressure over the pulp of the finger or the tip of the toes. After a few seconds, we find that the blanched area turns back to pink in a normal individual, whereas it takes more time in a ischemic limb.
Okay, next.
What is line of demarcation?
Line of demarcation is a zone between healthy viable tissues and the dead tissue.
It means what?
It gives the extent of the gangrene.
No, that is not the extent of the gangrene. That gives what do you understand by seeing the line of demarcation?
Dry gangrene.
It is dry gangrene. Okay. What is the color of the area of line of demarcation? Is the patient said anything about that particular area or beyond that area? The area below is not viable. There will not be any pain in that area. What will happen to the area just adjacent to the line of demarcation?
It is
It will be
increased tenderness
tender.
is seen and sensation, hypersensitive,
hypersensitive. Why?
due to
There will be nerve endings, no? Not audible.
Due to nociceptors, C and delta fibers.
So that is because of the nerve endings there, it is causing pain. And it will be tender on your palpation.
Next. What is Fusick test?
Fusick's test, also known as cross-leg test, we ask the patient to place one of his lower limb over the other such a way that the limb above is placed above the knee of the second limb. So we distract the patient by asking history, and we try to notice if there is oscillatory movements of the leg. It coincides with the popliteal.
Oscillatory movement present means popliteal artery pulsation is present. Okay.
So normally it's difficult to palpate the popliteal vessel, but if it is very prominently palpable, what do you think about?
It could be popliteal aneurysm or Baker's cyst.
Baker's cyst, pushing the artery anterior, right?
In cross-leg test, probably if there is aneurysm, it will be well seen, it will be prominent.
Next. Where to palpate dorsalis pedis?
Dorsalis pedis, we are,
Just to go for palpation, no need for any position change.
lateral to the extensor hallucis longus muscle.
At the level of
Muscle?
At the-
Muscle? Is it muscle?
Tendon.
tendon,
Tendon
At?
against the navicular bone.
navicular bone,
At the base of first metatarsal.
metatarsal bone. Antitibial artery? Anterior tibial artery.
Anterior tibial artery, it is felt in between the medial and the lateral malleolus, just above the knee,
Against which bone?
against the lower end of
Tibia. Posterior tibial artery?
Posterior tibial artery is felt lateral to the medial malleolus, in between the medial malleolus and the Achilles tendon, against the calcaneum bone.
Okay. Popliteal artery?
Popliteal artery,
Three methods are available.
Firstly, we could ask the patient to flex his knees to 135 degrees, and we place our thumb over the tibial tuberosities of the patient and the other fingers behind at the lower region of popliteal fossa, and we try to appreciate pulse.
Femoral artery.
Femoral artery in between pubic symphysis and anterior superior iliac spine against the neck of femur.
Radial artery.
Radial artery lateral to the flexor carpi radialis tendon against the lower end of radius.
What is Allen's test?
Allen's test is generally done to see if the radial artery and the ulnar artery are patent. So we ask the patient to flex his
And make
hands.
fist. Ask the patient to make a fist. Then
Make
you
a
compress both arteries. Then
And then we wait till 1 minute, and then we ask the
you ask the patient repeatedly open and close it. Thereby you can empty the veins. After that you release one vein, one artery.
Okay, sir.
It will change its color. Adson test.
Adson's test is we ask the patient to sit and we ask the patient to take a deep breath in and turn
Before that you palpate the radial artery.
artery.
Then you ask the patient
To turn the
same side and take a deep inspiration. In a case of cervical rib, the radial artery pulsation will be absent. Okay. Common carotid artery.
common carotid artery is felt medial to the sternocleidomastoid at the level of the upper thyroid against the C7
C6.
vertebra.
C6. What is Berry sign?
Absent carotid.
Because of
Hi. Invasion of
engulfment of the carotid sheath. Okay. Superficial temporal artery.
in front of tragus.
Tragus. Okay.
Next slide. Where do you look for murmur? What is murmur? What is bruit?
Murmur is heard over the arteries and bruit is heard over the veins. Both are heard. Shit, sorry.
No. புதுசா இருக்கு definition.
Bruit is heard when there is any stenosis or occlusion of femoral artery or popliteal artery. Murmur might be heard in AV fistulas, missionary murmurs. Heart.
What is reactive hyperemia test?
PP cuff is elevated at more than 250 mm Hg, and for 5 minutes it is.
You wait for 5 minutes.
5 minutes
Okay.
and then deflate it and see the time when the blood flow is reappearing.
Okay. Next. How to measure the power of the muscle? How many grades are there?
5 grades are there. According to MRC grading, first
Grade 0 is no power.
no power.
Grade 1? Flickering of contraction.
Flickering contract. 3
Grade
is
2?
Eliminate the gravity. 2 is eliminate the gravity. 3 is against the gravity. 4 is minimal resistance, they are able to move. And
5 is full
maximum.
power. Okay. Right.
So you have said sensation of the gangrenous area is lost. Gangrenous area sensation will be lost, no? It's nothing specific there. What is this expected? No, you have written sensation of the gangrenous area is lost. That is obvious. So what do you expect? Where you have to palpate? Previously we discussed, no, beyond the line of demarcation you should feel for the area of hyperesthesia or whatever.
What is the difference between gangrene and apoptosis?
Microscopic programmed cell death.
Cell death is
programmed
called
cell death
apoptosis.
is,
Right. Okay. Right.
Here obviously there is muscle mass is reduced in the calf area. What about the popliteal pulse in your patient? Was it present?
present.
Normal. Okay.
Next.
Diagnosis.
This is the case of peripheral arterial occlusive disease of the left lower limb with dry gangrene of the left fourth and fifth toe, probably due to thromboangiitis obliterans.
Why do you say it is TAO?
Because the patient's age is less than 45 years old and he's a male
Your
patient.
patient is a diabetic patient also.
But the involvement is a distal vessel, so TAO is more commonly affecting the medium size and small size vessels.
What is the definition for TAO?
It is an
It is
segment.
It is the pan-inflammatory disorder that affects the arteries, veins, and intervening nerves also. Okay. Right. Next.
Next, investigation, sir. So to confirm the diagnosis, first I'll take the ABPI of the patient and then Doppler or duplex scan, which is Doppler
What
plus
will you look for in ABPI?
Whether if the ABPI is less than 0.9, there is reduced flow to the
If it is less than 0.9, it is a peripheral
Peripheral
arterial
arterial
occlusion.
Less than 0.3?
critical limb ischemia.
Critical limb
What do you
ischemia.
expect in this patient?
Less than 0.9.
Is it critical limb ischemia or not?
It is.
Already gangrene established.
Point.
What is the clinical classification? What are the clinical classifications?
Boyd's classification.
Fontaine classification.
Fontaine and Rutherford's classification.
So where does this fit in? Fontaine.
Fontaine, it fits in grade 4.
Grade 4. Rutherford.
Rutherford, 6.
What is that? 6.
Major tissue loss.
Major tissue loss. Right. So what will you look for in the duplex?
Blood flow, turbulence, and level of obstruction. Is there any thrombus?
What type of flow you expect in this patient?
Monophasic flow.
Monophasic
Or
or
bi-
absent flow? Absent flow. Maybe an absent flow. Right. You have done a duplex. There is an absent flow, as you said, beyond the tibial arteries. What do you do next?
We should first we'll try to
Else.
posterior tibial is feeble, sir, so we might give chance for the limb to survive in
Right.
What is angle brachial index?
angle. Blood pressure is measured in both angle and brachial, upper limb and lower limb, and mostly it will be 1, but whereas in case of peripheral vascular disease, it will be less than 0.9.
Fine. Okay.
Is there any role of medical management in this patient? Patient is a known diabetic, hypertensive, on drugs already.
For pain relief, we may give, but no.
What is pentoxifylline? What is the role of the drug?
Pentoxifylline is a vasodilator which increases, modifies the shape of RBC and easy flow of RBCs into the
What is it called? Modification of the shape of the
Hemorrheologics.
rheology.
What is Raynaud's disease?
In Raynaud's disease, there will be
Extreme
Upper-
sensitivity of the
upper limbs.
arterioles to cold. That is common in females. Raynaud's syndrome?
It is secondary to any systemic diseases like
Like?
scleroderma,
SLE.
SLE scleroderma.
Okay. What is the treatment for Raynaud's disease?
Calcium channel blockers,
And
nifedipine.
avoidance of cold.
Vibrating-
Avoid cold exposure. Okay.
You have done a toe amputation. Right. What next? You have removed the gangrenous portion. Right. How do you proceed?
Dressing, wound deprivement and dressing regularly,
Okay.
and check whether the limb is viable in regular intervals. If further it increases according to the
What
level.
other things that you will give? What medications will you give for this patient?
Because the patient is hypertensive and all, you should give atorvastatin, cilostatisol, clopidogrel, and aspirin.
So you will give, what are for the peripheral arterial occlusion, what are the drugs that you will give for this patient?
Cilostatin,
Silostat, what is that?
phosphodiesterase 3 inhibitors.
What is the indication for that? Is it given in gangrene or something else?
Pain, clot,
Silastazole is given when the patient is having
clot,
intermittent claudication.
claudication.
Already there is a gangrene, so it's not needed here. What are the other drugs that you will give?
Antiplatelet
Antiplatelets, yes. Maybe a single antiplatelet
or dual.
or dual antiplatelet therapy. Then,
Hypolipidemic,
yes, what's that? What drug?
atorvastatin,
Atorvastatin or rosuvastatin.
Rosuvastatin.
Right. What next?
This area is already not having any flow, no? What will happen to the limb? You have amputated the involved diseased toes. What will happen? You said the other pulse is feeble. What will happen?
Blood supply may get further compromised and gangrene may extend.
Gangrene may
Extend.
extend, can go beyond. Yeah. Then how to prevent it? So by doing angiogram, you would have seen any
Collaterals.
collaterals. So if there is visible collaterals, you can plan next mode of treatment according to the presence of collaterals. Okay, you cannot go on doing amputation.
The patient is having ulcer or not?
No.
Suppose ulcer present, what is the management? Diabetic ulcer, what is the cause?
Neuropathy.
Neuropathic, then
Tra-
microangiopathy, then
Neuropathy, microangiopathy.
glucose laden tissue prone for infection. So what is the management for ulcer? What is ulcer?
Discontinuity in the lining epithelium.
Okay. How to manage ulcer? Non-healing ulcer. Patient is having very large ulcer, that is not healing.
Hydrogen peroxide. To
Even after applying hydrogen peroxide also, ulcer is there.
Negative. Non-healing.
What is graft? What is flap?
Graft. Flap has its own blood supply, whereas
Graft?
graft has
What are all the conditions to be fulfilled before applying graft?
blood supply should be there.
You should not directly apply over the bare bone or bare tendon. The area should be free from streptococcus. After applying graft, the area should be immobilized. Okay. What is meshing of the skin?
Sir?
Meshing.
Mesh. Split skin graft.
அதான் அதில் தான் கேட்குறேன்.
Placing
கிராஃப்ட் பார்த்துருப்பீங்களா, அதில் மல்டிபிள் ஹோல்ஸ் இருக்கும்ல, ஒய்.
to blood supply of the area. Micro.
The collected fluid will come out through the opening, otherwise the graft will be lifted away. Okay, right. Puma, time it's. Okay. Oh, thank you. Right.
Thanks.
Thank you.